Well, thank you for the introduction and thanks for the invitation to come. It's a pleasure to be here. So as Heidi said, what my objective for this afternoon over the next 45 minutes is, will be to give you some ideas about how we think spine control operates at these two ends of the spectrum, from the situation of healthy control, but also how that might change when people have pain. So what I'd like to do is start off with some discussion about what I think are the optimal characteristics of spine control. So how is it that a person controls the spine in an optimal sense? I'm going to use some examples that basically come from, I'm going to present them in a conceptual way, but are underpinned by a large number of different experimental studies. I then want to talk about what pain is, because I think for us to understand how the nervous system changes when a person has pain and how it changes the way that we move and control the spine, we really need to understand the physiology of pain. So what is it? And then we can understand why it might change in a certain way. I then want to talk about changes in motor control in people with pain, and I'm going to give you some discussion of that from two perspectives. I want to give you some clinical pictures. I want to show you how people with back pain move, and then I want to talk about some of the underlying mechanisms that can explain the changes that we observe in those people. Because my understanding is that if we can have a knowledge of the mechanisms that underpin why someone moves in a different way, we can have a better chance of then making that change with whatever intervention we might implement. And then finally, I want to talk about some implications for rehabilitation. I'm going to talk about some implications all the way through, but at the end I want to tie some things together just to give you a clear idea about how we can attack this issue of motor control changes from different perspectives. So, what is optimal control of the spine and pelvis? So I've got two videos that hopefully will show, and these are, well, one of them's moving, the other one is not. That's unfortunate. What I'm hoping to show you from these two images is two people running with very different styles. And in fact, the one on the left is exaggerating what he was doing, and that is when he runs, he doesn't move his spine at all. He's holding his spine rigidly. And the message I want you to get from this, and unfortunately the left one doesn't move, well, the message I want you to get is that control of the spine is not about making the spine stiff. There's a misconception that spine control is about spine stability, with the interpretation that spine stability is spine stiffness. And the message I want you to get is that that's not true. Spine control is optimal when you have a balance between movement and stiffness. A lot of exercise approaches that are directed to controlling the spine encourage people to make themselves stiff, to hold the spine and pelvis steady and move the limbs independently. We need to be able to control that alignment, but we also need to have some flexibility. And this runner on the right-hand side, what you can see is that he's being able to keep his spine upright, but he's also moving his spine. So it really is this very delicate balance. And he's moving his spine for a number of reasons. He's moving his spine to assist with the progression of his limbs through space. He's moving his spine to shock absorb. So every time his foot hits the ground, he gets a little bit of motion to absorb some of the impact. He's using movement to minimise energy expenditure. He's using movement to assist the coordination between breathing and running. He's using movement to be able to transfer the loads through his body. So ideal control is not about stopping the spine from moving, it's about finding this balance between movement and stiffness. So on one side, it is about controlling stiffness, keeping yourself upright against gravity, maintaining alignment, maintaining the translations at intervertebral segments. But at the other side of the equation is this movement for function, for shock absorption, load transfer, energy minimisation, and some variation. It's good if you move slightly differently each time you take a step so that you can share the load around different structures. So the first principle of optimal control of the spine is that it involves a balance between movement and stiffness. The second principle is that all of the muscles contribute to control of movement and stiffness of the spine. So there's no particular muscle that's most important. There are certainly small muscles that attach segmentally, and Heidi mentioned these little segmental muscles that attach from segment to segment that are very close to the spinal vertebra. There's muscles like the transversus abdominis and the diaphragm that attach extensively to the structures throughout the thorax and lumbar spine. The pelvic floor muscles, which I'll talk about in a moment, which have some relevance for the control of spine and pelvis as well. But you need to involve this entire multi-layer system of muscles to be able to provide you with the optimal means to balance movement and stiffness. But the contribution that different muscles make is unique, and that's for a number of different reasons. So if we think about the spine as this stack of blocks that are mobile in all different directions, 6 degrees of freedom, if all you had was big long muscles that attach from your thorax down to your pelvis, acting like the guy ropes of a flagpole, they'd be able to keep you upright, but they wouldn't be able to influence with great detail the relationship between individual bony segments. So you can't just rely on big long muscles to keep you upright. You also need to have a group of smaller muscles attaching segmentally that move with the spine and are able to sense and control intervertebral motion. So spine control involves a balance between movement and stiffness. It involves a balance between these small segmental muscles that can provide a contribution to intersegmental control, as well as the longer muscles which can generate large torques that can move you, that can hold you up against gravity. So you've got to have this balance between those different muscle systems. Another thing to consider is that these muscles attach to the spine through a complex array of fascia. There's been a great deal of interest in myofascial structures and techniques to influence the extensibility and the motion of fascial structures. From a mechanical perspective, they're critical because many of the muscles like the transversus abdominis and these other paraspinal muscles like the multifidus influence the spine through their fascial attachments. Transversus abdominis, it can only influence the spine by tensioning the thoracolumbar fascia. When multifidi contract, they expand and tension the thoracolumbar fascial structures here. So their interaction with the spine involves modifying tension in these fascial structures. One thing that you need to know is that abdominal muscles, they have some direct attachments to the spine that have some capacity to move the spine and keep it upright. But they also act on the spine through intra-abdominal pressure. So if you generate pressure, that can assist in the control of intervertebral motion, and we regulate pressure as a normal part of human function. One of the things that implies then is that when you need to control the spine, you also need to consider the roof and the floor of the abdominal cavity. And what that says is that the diaphragm and the pelvic floor muscles have a critical role in lumbopelvic control. And what that also then implies is that your nervous system needs to have mechanisms available to coordinate respiratory, continence, and spine control functions concurrently. And in a healthy system, that works efficiently. But in many people who have, for example, exercise-induced asthma or chronic airways disease, pelvic organ prolapse or incontinence, there is capacity for some of that system to break down and therefore have problems in the future. And we've done large epidemiological studies that show that respiratory conditions and pelvic floor conditions can be a precursor to the development of back pain in the future, probably through biomechanical means. So the neurophysiology of control of the spine is complex because it involves balancing movement and stiffness, balancing different systems of muscles, and balancing different functions like breathing, continence, and spine control. If we think about neural control strategies, I could talk to you about all of the different neural regions and the different pathways involved in movement control. But I think what's more important to consider is the principles that underlie the mechanisms of what's available to control the lumbar spine and pelvis. And this is the same for every movement, and that is that sometimes we can predict. If I'm going to take a step, I can predict what forces will be imposed on my spine. So I can plan in advance for that using feed-forward motor control strategies to prepare me for the disturbance, so I can pre-activate muscles to protect. But sometimes I can't predict because something is unexpected. The bus takes off quickly, or someone pushes me, or there's some another unexpected force. In that case, I can't prepare, I have to react, and I can do that very quickly. Sometimes it's as quickly as a stretch reflex. Sometimes it involves longer pathways involving the control of the entire body. So sometimes we predict, sometimes we react. But reaction takes time, and we can't predict everything. So we also need to have a third mechanism, and that's really to have a little bit of ongoing tonic activation of muscles to be there as a baseline, this general state of preparedness. So you have some general protection to which you can add or modify if there are additional forces that you react to or that you predict. So while I'm standing here, I'll have tonic activation of my soleus, I'll have tonic activation of muscles throughout my body, just in case I trip off the stage, just in case someone throws a glass at me and I need to stay standing. There will be all of these three strategies working at all times, and that complex array of muscles is going to be involved in generating that. So we know that the spine is controlled in this way. If you move an arm or you move a leg, trunk muscles turn on before you turn on the muscles that move your arm. This is a study we published more than 20 years ago that shows quite convincingly that preparation or feed-forward control is involved in control of the spine. Here a person's catching a load in a bucket. It pulls their trunk forwards and they react with a whole array of different muscles turning on at different times and different amplitudes based on what's necessary for that very specific disturbance. And then tonic activation. So here's a person running, and you can see tonic activity of trunk muscles continuing throughout the gait cycle, little bursts of activity every time the foot hits the ground, phasic changes as the person breathes. The nervous system is beautifully capable of being able to maintain tonic activation, bursts of predictive activation, and respiratory control all at the same time in the healthy situation. That all changes when someone has pain or a breathing disorder or some other deficit such as pelvic floor dysfunction. So the fifth thing I'd like to suggest is that it really is a spectrum. Heidi talked about this spectrum from normal to abnormal function. What I want to suggest is that in human function there's a spectrum from really static tasks such as pushing, pulling, lifting, where your primary objective is to stop the spine from moving. At the other end of the spectrum is dynamic control, where you really want the spine to move for shock absorption, for load transfer, for energy minimisation. So not every function involves the same balance between movement and stiffness. So hopefully what you can see is that optimal control of the spine and pelvis is a really complex interplay that the nervous system has this delicate capacity to control with precision in the healthy situation. But you can also see that there's a large array of possibilities for how that system might be modified or compromised by little perturbations in the system, either because of a dysfunction in the periphery, such as a pelvic floor dysfunction, changes in the neural control of breathing, or if the system is disturbed by injury or pain. So huge capacity for adaptation. So what I'd like to move on to then is to think about some of those examples of how the system adapts in the presence of a nociceptive input or a painful situation. And to understand that, I really need to just make sure that we're all on the same page in terms of understanding the neurophysiology of pain. And the first message I hope is really clear to you is that pain is not an input. You do not have pain in your tissues that you respond to. You have nociceptive input from your tissues, and your nervous system interprets that to determine whether it should be painful or not. Pain is not what comes from your tissues, nociception is. And nociception is not the same as pain because they don't match. You can have a large amount of nociceptive input and no pain. You can have no nociceptive input and high pain. They're not linearly related. So pain is the output, nociceptive input is really just a threat detection. If there is something thermal, mechanical, or chemical that is threatening your tissues, it will excite the nociceptive neurons and your nervous system will decide whether or not that should be transduced into a painful response. We have to have pain, at least in an acute situation. Pain is physiological. It is a normal and necessary part of being human. If you don't have pain, there is nothing to alert you to the fact that there is threat to your tissues, and there is nothing to motivate you to change. So if I was to fall over and sprain my ankle while I was running, if it didn't hurt, I wouldn't know that I needed to protect that structure. I wouldn't know that I needed to walk differently or to rest the structure in order to allow the ligaments to recover, to heal. So pain is there to motivate you to make some change to assist removal of the threat to the tissues. If you have appendicitis and you don't have any pain, there's nothing to motivate you to go to the doctor, and you'll end up with a perforated appendix. So it really is very clear. Pain is a necessary part of being human, at least in the acute context. But in a chronic situation, it becomes a problem because the connection between the motivation and its assistance to your tissues is gone. So in many people with ongoing pain, there can be an ongoing nociceptive input that is continuing to drive the situation. So there may be some tissue-level pathology that is continuing to maintain that nociceptive threat detection that your nervous system is reacting to generate this pain response. But don't forget it's non-linear. If someone tells you that they have 10 out of 10 pain, that does not mean there is 10 out of 10 threat to their tissues. Just have a think about when you hit your thumb with a hammer. You're putting in a nail, you hit your thumb, and it hurts. You look at it. If it's bleeding, it hurts more. If it's not bleeding, it hurts less. Your nervous system tunes or modulates the amount of pain based on the amount of threat. So it's non-linear. What you experience in terms of the output of pain doesn't necessarily tell you in a perfect manner how much nociceptive change or input there might be. So a patient telling you they have 10 out of 10 pain does not mean there's 10 out of 10 threat. A person who says they have 1 out of 10 pain does not mean that they necessarily have a 1 out of 10 threat. And that's because the pain that you experience is not only dependent on your nociceptive input, it's also dependent on complex reasoning and emotional mechanisms. If the threat is threatening, so if it's bleeding and there's clearly more significant tissue damage, it will hurt more. If last time you had this pain, you weren't able to work for 3 months and that was really important for your family's livelihood, it's going to hurt more. If you've got no way to continue to earn income when you're in pain, it's going to hurt more because of the threat value that that's proposing to your body. You've also got problems because of physiological mechanisms related to central sensitization. So your nervous system can be sensitized where there is amplification of the neural signaling so that you get more out depending on what you get in. And that can occur at a cellular level and a network level. So there are physiological or biological processes that can amplify this signaling, again, leading to a mismatch between what comes in and what you experience in terms of pain. So don't forget that when a patient comes to you with pain, there will be different presentations. Some people will come because they have pain that is definitely related to tissue. There is ongoing nociceptive information from their tissue that is driving a nociceptive input that is driving their pain experience. Their pain will generally be predictable and related to specific postures and movements and will be relieved by specific postures and movements. It will be anatomically specific and it will be proportional to the injury that they may have had and the loading that they produce. So that type of person is going to respond very well to an intervention that you might do that can act at a tissue level, modifying tissue loading, modifying the healing or recovery of those tissues. But there are other people who have pain that is based on central sensitizing mechanisms where there's amplification, and sometimes amplification to the point where normal proprioceptive input becomes misinterpreted as noxious. So you'll have a situation where a person continues to have pain, not because of threat to their tissues, but because of these amplification mechanisms. And a person who has that presentation will often have diffuse pain in multiple body areas that doesn't respond in a proportional and predictable way to movements and postures. And for that person, using techniques to modify the amplification, such as dealing with their psychology, dealing with the threat value, dealing with their catastrophizing, educating them about the physiology of pain, they can all be really helpful in enhancing recovery. And then, of course, there's people with neuropathic pain where the source of the input to their nervous system is from trauma or damage to neural tissue. And that can be peripheral neural tissue, such as sciatica, or it could be central neural tissue, such as the plaques in MS, or it can be after a stroke. So central nervous system neural damage leading to a painful condition. So neuropathic pain is not the same as central sensitization. It is a specific class of pain related to neural damage or compromise. So if they've got peripheral neural deficits, you might be able to modify nerve loading doing neurodynamic techniques or modifying posture to change the load on the sciatic nerve, for example. So different pain mechanisms, different interventions. But many of the people that we see will have combinations where there's a major player might be this ongoing nociceptive input or this central sensitization. And each of those is going to have some relevance to understanding how movement might change. So if we think about people with persistent pain, pain might persist because a person has ongoing threat to their tissues, where there is ongoing nociceptive input that requires moderation through treatment intervention. But there are others where their pain persists despite recovery of the tissues, and that would be someone who has more of a central sensitization presentation. All of them will have biological features, nociceptive input. These will have central sensitization. Psychology and social factors can amplify in both situations. In this group, it becomes a major component. So there's always going to be some biopsychosocial components to their presentation. What I want to focus on for the majority of the rest of the talk is really this situation where suboptimal tissue loading is relevant, because this is where motor control has a key role in the maintenance of pain, where the way that you use the body, the way that you move, the way that you control alignment is driving your pain condition. So how does motor control change in people with pain? So I really want to focus first on some clinical presentations that show how people might adapt their muscle activation, posture and movement in a way that might suboptimally load the tissues of their body. And I'll take posture first because it's a straightforward example, where there's different ways that people might sit that can have abnormal loading or suboptimal loading on their body. For example, a person who always adopts a flexed flat spine who may put excessive loading on the dorsal ligaments, on the discal structures. A person who may load their spine excessively by strongly contracting their paraspinal muscles to stay upright because they're scared that every time they bend forwards they're going to blow a disc. So a really common presentation is overactivation of extensor muscles. And then there's people with a sway back who hang into extension. So each of these three different loading strategies might present as a way that the person is driving or continuing to maintain suboptimal loading of their structures of their spine. And there's a whole range of studies now that show that different subgroups present in the back pain population where different postures are related to the provoking and relieving people's pain. Movement adapts in a similar way. There are some people who move not enough, so this person is not moving their spine at all, so they're holding their spine rigidly into extension. And this person has a sway back. Every time he comes up, he thrusts his pelvis forwards, so he's getting excessive motion every time he moves. This person, every time they move their hip, they move their pelvis and spine instead of their hip. That's what you should have. Control here, movement here. But this time, every time he rotates, all the motion's happening above. So Shirley Salmon has lots of data to suggest that people involved in rotation activities who use those types of strategies appear to be more likely to develop pain. So the way you use your body can be relevant for tissue loading, and that can be relevant for the presentation of pain. Muscle activation is similar. There's a whole host of different studies that show that muscle activation can be compromised. So failing to use muscle activity sufficiently to be able to control the motion and alignment of different spinal structures. So there's lots of data from studies of arm movements and leg movements. So before I showed you that when you move an arm or a leg, you pre-activate muscles. Many people, when they have back pain, fail to pre-activate, at least with certain muscles of their spine. So sometimes it's with the abdominals, sometimes it's with the little short paraspinal muscles, the multifidi. There's evidence that people fail to use that tonic preparedness. They don't hold their muscles tonically in that steady state of getting ready. They just phasically burst their muscles. There's also evidence to suggest that not only do some people use their muscles too little, some people use them too much. Excessive muscle activation will have excessive compressive load on the spinal structures. And there's lots of evidence from epidemiological studies and from biomechanical studies that show that many people with back pain use too much activation. So Morash showed increased co-contraction leading to excessive load in back pain patients when they lift. We've shown evidence of decreased shock absorption of the spine in many people with back pain and less variation, so less sharing of load between structures. So back pain can involve too little and too much activation. So both ends of that spectrum, because everything's about a spectrum or a balance, is a problem. But we also need to remember sensory function, and motor control involves sensation. You can't control movement unless you can sense where you are and how you're moving. And there's lots of evidence to suggest that people with back pain have problems with proprioception. There's problems with the input coming from the receptors in the tissues of the spine and pelvis and muscles. There's also inaccurate use of that input. So the input might be coming from the structures of the spine to tell you where you are, but then your nervous system might be inappropriately using that information, misinterpreting the position and movement. And then there's a whole lot of data that comes from some imaging studies and some other biophysical testing that suggests that the person's representation of their body on their sensory cortex is distorted. So the shape and nature of the body on the cortex is adapted. And of course, that final thing I mentioned before is that you can also have dysfunction of these other systems like breathing and pelvic floor function that can compromise ideal control. So people with breathing disorders are more likely to have back pain. People with back pain often breathe differently. People with pelvic floor dysfunction are more commonly presenting with back pain, probably because this whole control mechanism is suboptimal when those muscles are not being controlled appropriately. So what does that mean for rehabilitation? Well, I think one thing it means is that we need to be really specific. We need to consider the type of pain. Is it related to the person's movement? Is it nociceptive in nature, or is it central? And that will give us some indication about what type of intervention we might use. Is it based on their movement features? So are there specific movements and postures that we should be targeting for that particular patient? And we need to think about multiple systems: sensory input, respiratory system, continence system, all of those. So what are some of the underlying mechanisms? So a person presents to you with pain, and there is a very tight relationship between pain and movement, but it occurs in different directions. The first thing we need to remember is that many people get pain in the first place because of some suboptimal loading event. They may have been lifting poorly for many years. They may have been sitting in a poor position for many hours, for many days. They may have been in a car accident. They may have lifted in a rotated position. So there may have been some mechanical event that's led to tissue injury and pain. But once they come to you, that's already happened. What we need to consider is that pain can then have an impact on the way that you move. So pain can influence then the way that the motor system functions and the sensory system functions, and that can lead to further problems because it's modifying your motor response. So one way that it can modify your motor response is by interfering. So pain and tissue damage can interfere or lead to inaccuracy in the way that you control movement. And I'll give you some examples. So if we think about the motor system involving everything from the motor cortex to the deep brain structures to the brainstem, the cerebellum, the spinal cord mechanisms and the muscles, so this whole host of different structures and regions throughout the neuromuscular system, this inaccuracy or interference can occur at any of those levels. Let's think down at the muscle spinal cord level first. An example which is commonly discussed in the literature relates to the paraspinal muscles, particularly the multifidus muscle. And what you can see here is MRI scans of the multifidus muscle in someone with acute back pain, subacute and chronic. And what you can see is a massive structural disruption of the multifidus muscle with this fatty replacement in the muscle. So there's the spinous process, the lamina, all of that's multifidus, and in this chronic patient you can see clearly almost half the muscle mass is replaced by fat. So in the acute phase we see atrophy, and then over time there's fatty infiltration, fibrosis, and muscle fibre changes. So dramatic changes in the end organ, so in the muscle itself. But in the early phase, it's really neurally mediated by reflex inhibition. So if you see a patient within 3 days of an injury to their spine, there'll generally be some atrophy to this muscle, just like there is atrophy to your quadriceps muscles after you have an acute knee injury. We've demonstrated that in humans, and we've also been able to show it in animals. So in sheep and pigs, if you give an intervertebral disc lesion, you get atrophy of the multifidus muscle that occurs within 3 days. So this is loss of 20% of the cross-sectional area of the muscle within 3 days. And that's mediated by reflex inhibition. So when we excite different levels of the nervous system, we can show that there's a reduction of spinal cord excitability. So it's harder for the nervous system to drive that muscle because of reflex inhibitory mechanisms at the spinal cord. So in the acute phase, what we see is that this injury and pain is interfering. It's preventing you from using the muscles that control that particular segment. So it's a localized change related to reflex inhibition. Over time, things change. So when we look in the subacute phase, so anywhere from about 3 months, 6 weeks to 6 months, we see that there are changes in structure of the muscle itself. If the muscle structure is changing, even if the nervous system was working perfectly, it wouldn't be able to control the muscles appropriately. So what I'm showing you here is the multifidus muscle of a pig, and what we've been doing is looking at the structural changes in connective tissue, in fat, in muscle, and the molecular changes that subserve those tissues. We see changes in muscle fibre type. So it's a little bit hard to see here, but the pink muscle fibres are the slow fibres that are the tonic ones that you need for that ongoing level of preparedness. The pink ones are the fast ones that are there for force. The brown ones are the slow ones. And what you can see here is that there's almost no brown fibres left. There's no slow fibres left. So what's happened is that they've lost that tonic preparedness function of their multifidus muscle. So the muscle is changing in what it can do. There is also changes in the connective tissue, so more fibrosis and more fat within the muscle. So the muscle is losing its contractile component. So again, losing its ability to control. And we've shown that that's mediated by inflammatory response. So a local inflammatory response driven in the muscle by the macrophages. So there is actually an active process in muscle that's causing this structural change. So you start with this neurally mediated phase of inhibition. Over time, that goes into a pro-inflammatory phase where you start to get this fibrosis and fatty change in muscle, which is very similar to the change that you get in your kidney and your retina and other tissues in diabetes. So this systemic inflammation, this muscle-related inflammation, is a really common feature in many chronic conditions, including chronic pain. And then in the chronic phase, there's massive disuse. So you start to see really gross and generalised disruption of muscle simply because the person's not using the muscle anymore. So they've lost the function. So that's going to have a profound impact on sensing movement and position of the spine, but also controlling it with finesse. So different mechanisms at different time points. I think that's got a really important clinical implication because what it says to me is that in the early phase, we don't just want to use exercise to just do high strength training. We actually want really delicate exercise to overcome inhibition. In the subacute phase, we need to have a pro-inflammatory effect. I don't think that means just using anti-inflammatory drugs, because exercise, I think, we know, is an anti-inflammatory stimulus, and we can direct it to the right tissues in the right way at the right time. I think I'd be much more keen to give a person an exercise than a drug to have a very localised and specific anti-inflammatory effect. And we know we can do that in muscle. And then in the chronic phase, where there's this massive disuse, we really do need to teach people how to use their bodies differently and then load, do some more stronger whole body exercise to try and provoke recovery. And we've just shown that that's the case. So in mice, we have a specific mouse model where they lack a specific gene which causes them to have absence of a protein that's necessary for controlling the structure of their intervertebral discs. So these mice spontaneously rupture their discs, and what we've shown is that those muscles mice undergo the same muscle changes that we see in humans in terms of the molecular changes of muscle structure, but you can reverse that by exercise. So getting the mouse to run on a wheel, you can reverse the muscle atrophy. So in humans, I think what we need to do is to teach them how to use the muscles appropriately and then load them to reverse those changes, at least when they get into the more chronic context. So pain can interfere, and what I've shown you is at the spinal cord level and at the muscle level, pain and injury are interfering with the ideal control of the spine and pelvis. But it also happens right up the top. So right up in the motor cortex, there's changes where the way the finesse of control of muscles is modified, leaving you less ideally controlled to manage the forces imposed on your body. So I showed you these studies before that gave evidence of control changes, and what we've been showing is that these control changes of muscle are related to cortical changes in the way that your body represents these muscles and movement patterns in your motor cortex. We've shown that for back pain, and we've also shown it with knee osteoarthritis using some fMRI experiments. But I just want to show you a couple of observations. One way that we can probe the organisation of the motor system is by stimulating over the brain with a few thousand volts. So you run a few thousand volts through a copper coil, it sets up a magnetic field that passes through the skull and excites the cells in your cortex. You really don't feel very much. It gives a little contraction of the scalp muscles, but because it's just the magnetic field and not the electric current that's passing through the skull, it's relatively painless. But what we can do is very precisely stimulate different regions of the motor cortex and then measure the response in the muscles. So we stimulate the brain, 18 milliseconds later approximately we get a response in the muscles around the spine, and if we stimulate over a grid, we can identify the region of brain over which you get the biggest response from the muscle. So we can work out something about the map or the organisation of that muscle on the brain. So what we've shown is that people with back pain have a shift in their representation of abdominal muscles, and how much that representation is shifted in a posterolateral direction relates to how much that muscle might be delayed when they perform a movement task. So a clear association between a behaviour and a central organisation feature. In the paraspinal muscles, normally different muscles, like your little segmental muscles, are controlled separately from those long guy ropes. So different regions of the brain control that fine intersegmental control than the ones that control the force and upright alignment. So different regions for different functions. People with back pain, often they'll have a single representation for both. They lose that finesse of separately controlling different muscles. So what I've suggested to you is that pain can interfere at multiple levels of the nervous system. I've given you an example down here of spinal cord and muscle changes, and as I mentioned before, there's a host of examples to show changed nervous system function and proprioceptive function in people with pain. For example, in a person with no back pain, this is the area of brain that senses the back. In a person with chronic back pain, it's somewhere else over here. And the longer you've had pain for, the further away it is. So there's a distortion of how you think the body is represented. So pain interferes, and that can lead to suboptimal control. Implications for rehabilitation. Clearly what I think it means we need to do is to restore some of those features. If we find that the multifidi are being compromised, we need to modify that. If movement is abnormally loading because there's interference, we need to deal with that by changing the movement control strategies. Another way that pain interferes or pain interrupts movement is by evoking a protective response. And this makes a whole lot of sense. If it hurts, stop it from moving so you don't get further injury. So if there is a real or threatened input from the tissues, you will change your movement in order to protect you. It might be very subtle, like simply tweaking or modifying muscle activation to change the alignment or orientation of force. Or it might be a major adaptation, such as resting in bed, not moving at all, in order to stop yourself from having any problems with loading. But the objective of that is to change your motor output in order to protect you from further pain and injury. Bracing your trunk muscle so you don't hurt your back, externally rotating your legs so you don't dorsiflex to hurt an injured ankle ligament. So, it gives you a short-term benefit of protecting the structures. But what I'd like to suggest is that this may not be ideal, and it's also not straightforward. So here's an example of a study that we did several years ago where we gave people pain. We recorded from multiple different muscles around the trunk. We injected salty water into their back muscles to give them a deep muscular ache. It lasts for about 15 minutes, and its purpose is to give you an acute nociceptive stimulus. It's not clinical pain, it's acute nociception. How do you respond? You would expect that you would respond by stiffening and protecting your back to stop it from moving so it doesn't hurt. And on average, that's what people did. Everyone had a bit more protection of their back. But they all did it differently. Here are the 12 different muscles. Here's 17 different people. This person, all they did was increase. So blue means increased, orange means decreased, black means no change. This person only increased their thoracic erector spinae on the right and on the left. This person only used their latissimus dorsi. This person used almost everything. So what you can see is different people's nervous systems choose different solutions to protect. So what that says to me as a clinician is I need to have the sensitivity to understand what it is about a person in front of me that is modified so that I can be precise in changing their adaptation. Because our idea is that if you use these techniques, these strategies in the short term, there's benefit. So co-contracting muscles, increasing activation to stop you from moving, that's great for a few days. But you really don't want to do it for 2 months because our idea is that that will have, in the long term, negative consequences. So there is some suggestion that if you co-contract muscles for too long a period, you'll have too much loading of the spine, less movement, less variation. And what's been shown by some work from Jacek Kolovecki is that people who have too much muscle activation when they do specific tasks that challenge that system, they're more likely to get a second episode of back pain. We've shown that when people with osteoarthritis use certain protective strategies, their osteoarthritis progresses more rapidly. So these strategies can be problematic in the long term. So for rehabilitation, what that tells me is that we need to consider the adaptations that people make. It makes sense in the early phase. Pain motivates you to change your behaviour. But in some people, those adaptations may persist. They may continue to brace. They may continue to walk abnormally, which then may develop into these secondary problems through extra loading, poor movement, poor variation. So recovery may depend on us being able to break up those protective and excessively maintained strategies. So too much protection also feeding into this problem. So a few words to finish off with then in terms of rehabilitation. I think what this all tells us is that pain is often the consequence of mechanical loading because of disruption of tissues. But then pain can make the problem worse by interfering with the motor strategies or generating new motor strategies that may in the long term be problematic. And again, each of these things then can excessively load the tissues, perpetuating the problem. So I think we need to address the way that a person loads their body. So I think we need to consider that if load on the tissues, and they may be sensitised, is continuing to maintain nociceptive discharge, contributing to the person's pain, then changing the way a person moves their body may be relevant for their recovery. So motor control strategies of changing the way a person uses their body make sense. And we've done a whole host of different experiments that show that we can change the structure and behaviour of muscles. We can make these compromised muscles enhance their recruitment. We can reduce the overactivity. We can improve proprioception. We can change posture. We can change movement. So it is possible to change each of these features of a way a person's using their body. And there's clinical trials that have done that in a very specific way to specific subpopulations of patients that have had really potent and large clinical effect sizes. There's another group of studies that have applied the same treatment to everybody. They've taken every back pain patient and they've treated them with the same series of exercises, and it's not really surprising that the effect sizes are smaller Because I think the whole purpose of these interventions is to be specific, is to identify what it is that needs to change and change it. So if you do the same thing to everybody and you treat people with central sensitization exactly the same way as you treat people with nociceptive input, it's not going to be so effective. So I think we need to change loading, and I think we need to be specific. But I think we also need to consider that some of the interventions that we do might in fact deal with some of the drivers of that inaccuracy. Spinal manipulative therapy may be one way to reduce that input that is driving inaccuracy. So normalise the input from joint structures so that a muscle can recover its function. So maybe that's one way that we can get into the system. But we also need to really very specifically address these protective strategies. If someone's overprotecting, it can be a problem. So I really think that the relevance of the motor system is incredibly important in people with pain, but the final message I want to leave you with is that, as I've said all the way through, not for everybody. Because some people will have pain that is related to ongoing nociceptive input, where loading of tissues is relevant. Their motor system is a really important component of driving that, and addressing that is critical with intervention. But at the other end of the spectrum are people with primarily central changes where pain is being maintained despite the absence of nociceptive input. So changing the way that person moves will not directly impact on their pain. Exercise can still be beneficial, but more as a psychological cognitive behavioural intervention than something that's changing the underlying cause of their pain. So what have I said? I've said spine control requires a balance between movement and stiffness that involves coordination of this complex system of muscles, that involves a range of neural mechanisms, and trunk muscles need to also be considered in terms of respiratory functions, continence functions, these other systems. I've said that pain and motor control interact in multiple different dimensions, that motor control and pain have positive and negative implications. So you may adapt in the early phase with a positive outcome of protecting those injured structures, but in the long term, that can be a problem. That in persistent pain, nociceptive input may still be important and therefore require a motor control intervention, but it may not. And then treatment needs to be targeted to the individual. There is not going to be one treatment that's suitable for everybody, and our challenge is to find out who will do best with what and when. So I'll finish then just by acknowledging the many, many people I've worked with for these experiments and the people who've given me the cash. So thank you.